Screen?
Yep.
Okay. I've got a lot of slides, but it's mostly pictures. So look, I haven't done this topic before, but I've just basically put together some slides about the classifications I think are really important to come up all the time. And I think that's quite important. And I'll just show a few examples of how certain conditions are dealt with, just to remind the guys that are coming in what we do and the names of certain things. But absolutely happy to stop any time and just discuss something. But hopefully I'll give a decent overview here. So before you get to your investigations, you must just ask for, just ask a few things. And so the examination is really important. So when you're like in those trauma meetings, always before you want to venture comment on the posterior element, just say you're going to log roll the patient, you're going to palpate behind, feel for your tendinous gap, and you're going to do a PR at the same time. Okay. So your investigations, your examination is really important in the context of that. We know these guidelines. So patients with with suspected neck trauma who don't need X-rays, so neurologically normal, no intoxication, no tenderness, no distracting injury. These guys don't need an X-ray. You can exclude an injury on clinical grounds. So Rob's quite big, and I guess I'm as well on reading an X-ray properly. We don't even want to do CTs, but you can tell a lot of information on a simple X-ray. And I'll just go through a line. So for those who know it, that's fine. Just refresh your memory. On the lateral, you want to start with your soft tissue line. So how do you know when it's swollen or not? So what's not normal? So Rocket and Green talk about the numbers 10, 5, 15, which sort of stuck in my mind. So by C1, you're like 10 mils. Between C1 and C5, you're like 5, and below that's 15. Or you can think about full body thickness below C5. What you're looking for is a fusiform swelling in those lines, okay? So a swelling there would be indicative of a problem. And that's just showing you soft tissue trauma, okay? So your first soft tissue line, when you start at X-ray, first thing you go for is your soft tissue line, okay? Then the next one's the anterior body line. And you've got to have nice, smooth arcs, okay? You want to see that there's no step in the line. That's your posterior body line. And these two lines are very easy. Don't forget them. Just go through them and you won't forget stuff, okay? But look how the posterior body line goes up to the back of the peg. It's almost a straight line. The back of the C2 there and the peg is one continuous line, okay? The anterior body line goes to the front of the peg. And the next line is a spinal laminar line, okay? Which sounds easy, but you often get confused when you're focusing down here because the facet joints can confuse you. So if you're not sure, look at C2. You don't see the facet shadows, and there's quite clearly the line there. So the base of the spinous process, and where it joins the lamina, that's your spinal laminar line. It's a nice hard line, and the importance of that is your spinal cord runs there. And the last line is your lines of convergence. There's no spinous process line. It's all rubbish because they're all different lengths. So you want the lines of convergence. So it's just an imaginary line drawn through, imaginary line drawn through the body. I've got a thing here. And they should all converge. And basically it draws your eyes to the fact that the neck should be in lordosis. If you have a segmental, like a listhesis or something, you'll see the lines will diverge at one point. Okay. Look at the intervertebral disc height and look at the bodies, make sure they're all symmetrical, not flattened. Yeah, that just shows you diagrammatically the spinal laminar line, and that's the base of spinous process, and that's where your cord runs in. There's lots of space behind C2 as well. That's why you very rarely have a cord injury by C2 fractures. Look at your ADI. Should be less than 3 millimeters in adults, less than 5 in children. Because in the children's, the ligaments are more elastic, so you allow more translation before it fractures or ruptures. The back of the peg, as I said before, is a straight line at the back of the peg. And if you follow that line, you should follow and see the tip of the odontoid process, which aims towards the tectum over here. Sorry, obviously this line is, if this gap's big, then you're worrying about a cranio-cervical, cranio-cervical dissociation. You can also see the condyle sitting nicely in the sulcus in the C1 arch. That's also a giveaway if you find there's asymmetry in this joint, the C0, C1 joint, then it means that's subluxation, and it's usually because of a cranio-occipital dissociation. That's showing where the cord goes. On the open mouth view, you want to appreciate the odontoid peg and the lateral mass of C1. Remember, C1's a ring, so any axial load will cause it to split apart. Make my video smaller. So there's also transverse ligament keeping the lateral masses attached to the peg. And if you have enough axial load, the C1 will blow apart, and you'll have this will overlap. And if the combined overlap is more than if this combination of this distance there and that distance there is more than 6.9 millimeters, then it means it's gone far enough to rupture the transverse ligament, and that's an unstable C1 or Jefferson fracture. Looking at the AP view, always look at the spinous processes. Any dislocation or subluxation may cause rotation, and you'll see it like that. So in this instance, the spinous process moves to the left, which means that the neck is rotated to the right. Look at your facet joints. So they should be nice. If you have a true lateral centered over the facet joint in question, there's no double shadows, because they in there you can maybe see a faint shadow there. So if you rotate the neck, they'll move in this direction, okay? They'll move like that. That's rotating a neck. So if you think of a unifacet dislocation where the two below ones stay unrotated, the two above ones rotate, that's your bow tie sign, okay? So if one facet jumps, then you're gonna have rotation above that level. Other thing we sometimes get confused from is parallax. So if you're not centered at that facet, if you're looking obliquely, you'll see that sort of double shadow. The back of the facets are in lines, there's no rotation, but your parallax error gives you a double shadow below it. Okay, so that's not rotation, that's just poor X-ray. So if you center your X-ray at this level, this is C4, then you'll have none of this parallax. Okay, there you can see there's obviously a dislocation because you've got a step, the LL, posterior body lines is ruptured, the spinal lamella line, your lines of convergence are now diverging there. Yeah, so you can see here, there's parallax, so there's a bit of a double shadow there, but there's no rotation here, okay? It's almost in line. So how can it be jumped forward if there's no rotation? So a bifacet doesn't give rotation, but the clue this is not a bifacet is that it hasn't moved more than 50%. Or to jump both facets, the body probably has to move more than 50%. So this looks like unifacet, and what I'm seeing here is a double shadow here. So here's your bow tie. So they've taken the X-ray with the the caudal part of the spine being rotated, and the one above being unrotated. So it's either one or the other. Yeah, so it just shows it there, what's happened there. Same story here again. You can see there's no rotation above the dislocation. There's a facet which has got nothing above it. So it's definitely one facet's jumped. You haven't seen the other facet, and there's contact there, so it's a unifacet dislocation. Also, you can see it's less than 50%, so it tends to be unifacet. You look at the X-ray, you can see that's the midline. There's a spinous process off the side there. bifacet dislocation. So you tend to be more than 50% translation. And looking here, you can see there's no rotation, both facets in line. Over here is no rotation either, but what you're seeing is parallax. If you look at the above the one, there's no rotation. So there's parallax here, but there's no rotation. So more than 50% translation, both facets jumped. If you look at this level here, you can see both facets nicely. There's no facets on it, so it's definitely a bifacet dislocation. Also in the AP is no rotation. The importance of spinal lemma line, you'll see. So the spinal lemma line dimensions doesn't change here, okay? It's a simple dislocation. But if you look at this picture, you can see there's a clear step in the posterior body line. But the spinal lemma line hasn't got a step. So that means that this space there has not changed, but the one above it has changed because there's a fracture in the lamina. So if you've got a step in the body, but the spinal lemma line's got no step, your posterior elements are disconnected from your body. All right, so this is a fracture dislocation. And it's a bifacet because I can see these two facets are empty. There's no rotation. These cephaloid ones with no rotation either. Okay, it's not a bow tie. So this is a fracture bifacet dislocation. Sorry, it just shows your spinal lemma line, which has got no step, but your posterior body line's got a step. Okay, let's just jump through this, same stuff. So looking at C1 fractures, it's a ring fracture, so any fall directly fall in the head, your occipital condyles will cause a sort of a ring to blow out. Probably because the slope of the shoulders is C2, it just tends to blow it out. So you can diagnose in an open mouth view, you see overlap, and sometimes if your transverse ligament's ruptured, then your peg is able to move unrestrained forwards or backwards, and you get a larger ADI. It may be your ADI is large because you've got an anterior part of the ring fractured as well, huh? Okay, so here you can see there's a large ADI, it's more than 5 mils. You can also see your spinal lemma line. So that's the line there. And that's also got a step. The whole C1 rings come forward. That's the transverse ligament rupture. There's your peg sitting nicely in the middle of the canal where your spinal cord should be sitting here. So deciding if your C1 is stable or unstable, we call it the rule of Spence. So if your sum of your lateral masses is more than 6.9, so if the overlap is more than 6.9, that plus that is more than 6.9, that means your transverse ligament's ruptured and it's an unstable injury. How do you treat that? Bonner? Bonner sleeping. Fidelis?
So yeah, if it's unstable, C1, C2, first thing that comes to mind is a Harms fusion if we're going surgical.
So the first, what are you going to do when you first see this unstable C1 ring fracture?
Yeah, so I start with my basics, just inline stabilization. Luckily for the patient, this type of injury doesn't normally come with a cord injury because you're actually opening up the canal. So just, yeah, stabilize all of those things, put on cones.
Cones, yeah, cones calipers, just simple around tracking, okay?
Cones calipers, yeah.
So that should be fine. So look, the transverse ligament may pull a piece of bone off, okay? I'm not sure I've got a picture of this. I might have. So if your transverse ligament pulls the bone off, that can unite and it should stabilize, okay? So they're not all unstable. So if you can maintain a reduction in traction and you give it 6 weeks, you can then set them up and see what the ADI is like. If the ADI is normal and preserved, then they can be treated on a Philadelphia collar. If they still have instability after a period of 6 weeks, then you may choose to fix them, okay? But it's quite a lot of there's a lot of loss of motion to fuse the C1, C2. You lose 60% of your rotation. So it's not something you want to like rush for. It's also quite tricky to fuse it if you've got a C1 burst fracture because the fragments are floating around in the air and your visual artery is running through there. It's not the easiest fixation. But yeah, so the option is a Harms fusion. So This is another algorithm. So the bony avulsion expected to unite, so you can immobilize it. We don't have external mobilization. We don't have halos, so we treat them in cones. If there's no bony avulsion, a C1, C2 fusion, that's probably correct. But if you've got a C1 ring fracture, you remember you're also damaging this joint. And if you immobilize for 6 weeks, you're probably getting a sort of fibrous ankylosis, and the joint's quite stiff, so it may not be unstable. So also in our environment, I'll treat them for traction in 6 weeks, then see what they're like. They may be stable in terms of the fibrous sort of fibrous ankylosis, and they may not need a harms. But obviously, if there is instability and persistent, PEG, ADR, then you may want to do a harms fusion. And I'll show you what a harms fusion is just now. So the traditional fusion is called a galley, which basically sublaminar wiring, and you put a H-shaped graft of bone there, and that's what you had. But it's got very poor rotational control, and you can't really change listhesis. So, and also if your arch is fractured, it doesn't help, eh? So we don't use sublaminar wiring anymore. Other way of fixing it, you can do a transarticular screw, which is basically, there we go. So the transarticular screws going through the C2 isthmus, through the C1-2 joint into C1. You're missing a cord by 2 mils, you're missing a VA by a couple of mils. Yeah, so I've done a couple of those. But to do a C1-2 screw, you have to have it, the C1 and C2 aligned. You can't use a technique to align them for you. So it's not reducible, you can't do that. So transarticular screw, and then we got the harms fusion, that's what Brad mentioned now. So it's basically pedicle screws. So C1 lateral mass screws there, and then C2 pedicle screws, and you can then pull them back and reduce the subluxation. And the harms fusion is probably the default technique to fix these now. Here's a nice harms fusion done as well. Okay, so that's that. Looking at the PEG fractures, you can see a lot of those. It's usually a young person's injury or an old person's injury. It's a bimodal distribution. Old people is a fragility fracture. It's similar to a neck or femur fracture. So the same, I guess the same risk factors apply in terms of survival and stuff. It's an end of life fracture. But in young patients, it's a high energy fracture, and usually either hyperflexion or hyper extension. And it's unusual to have neurological deficit because there's a lot of space there. It's Anderson-Delonzo classification. Type 1 is just a tip avulsion. That's always stable, a filly and go home. Type 2 is for the waist, and the type 3 is in the body. So on the CT, anything dipping into the body below the shoulders is a type 3 fracture, and you want to see it in a coronal cut, not necessarily the sagittal cuts. The problem is, yeah, so the type 1s, you go home in a collar. Type 3s, we're going to put in traction 6 weeks, and then 6 weeks in a Philadelphia collar. The type 2s are the pollen ones. They get poor blood supplies, a watershed area, and so on, and they have higher non-union rates. So just remember these factors for non-union. So there's displacement, larger than 4 mils, angulation, or older patients, they tend to not unite. That PEG is like a piece of tibia. It's rock hard bone, and it's got very poor blood supply, so it doesn't unite very well. So you can fix it. You can put a Odontoid screw. It's quite a fiddle. You got to set your 2 dual C arms up there. You can't fix it if you got a reverse oblique fracture line, because it's just going to place it more. So you want the fracture line to be transverse with a screw. You set the patient up, and you can put 1 or 2 screws. They're both described. The problem with a PEG screw is you got to start. You can see here you got to start. Your angle is so short. You also got to start in a C2-3 disc. Otherwise, the screw just cuts out anteriorly, and it's quite hard to. You've got to also have the PEG lined up. So here's the PEG displaced, and you can arrange it. The patient's in a Mayfield clamp. Then you put the screws through. The but it's quite tricky. You often do damage a 2-3 disc, and the screw may come out the back. You've got a guide wire. The wire might, with you drilled on the guide wire, the wire goes into the head. All becomes very awkward. So it's quite a fiddly technique. And don't forget, it's not just a peg fracture. You've actually dislocated your C1, C2 joints. And so what we do after fixing these pegs, you put the patient in a Philadelphia collar, immobilized for 6 weeks. It's like taking a dislocated knee and put it in a brace and not move it 6 weeks. You're going to get stiffness. So the C1-2 joint gets inevitably stiff, ankylosed up. So all this effort to keep the peg, to fix a peg to preserve motion doesn't work. Rob reviewed all these papers, and they they don't understand. They're measuring subaxial motion, not peg motion. So it's a hell of a fiddle, and you tend to not get the movement you're trying to get. So that's one of done studies, and you'll love it if you can quote that. So we tend to fuse them, and this fusion is just a Harms fusion, simple, reliable. You don't have to have the peg lineup. You can use the Harms technique to reduce it. And that's pretty much what we do as standard of care here, the Harms for a non-united or unstable type 2 peg fracture. Traumatic spondylolisthesis, that's a so-called hangman's fracture. It's basically a patient always have a blow in the head. You extend the head, and it's called a force-out mechanism that causes a shear force. And you get a fracture through the pars of C2. A type 1 is stable. It's less than, I think, 3 millimeters of translation. That can be put in a Philadelphia collar and sent home. The type 3 is a fracture with a dislocation. You almost never see that. Sorry, type 3, yeah. The type 2s are the ones which are slightly unstable. So the type 2, there's more than 3 millimeters of translation. The 2A is a special one. You've torn the PLL, and that's highly unstable. And you don't really want to put that in traction because you get massive over distraction. So you can see how that disrupts the C2-3 disc. And if you torn the PLL, then you can have quite a bad over distraction to that peg. There you can see, it looks like a minimal translation. There's a bit of a fracture. This will heal quite nicely in a collar. It's a type 1, So collar, that's fine. So when you have marked angulation of C2 and C3, or anterior translation, or large fracture gap, that you must suspect that there's a 2A. Let's show there. There you can see that posterior longitudinal ligament has been ruptured totally. Okay, huge hematoma. And you put this in traction, he's going to get a large gap here. So that shouldn't be kept in traction. So just to summarize, the type 1, you treat in a collar, send home. The type 2, you put in traction to line them up for 6 weeks, and the pars heals. Just be careful, it's not a 2A. So if you get marked angulation, a large gap at the disc space here, you don't MRI them all, then you must worry about 2A. So if you're not sure, put maybe 2 kilograms on and take immediate X-ray and check it's not over distracting. And if it copes with that, you can maybe put 5 Ks and take immediate X-ray to make sure it's not over distracting. We've had one lying in ICU for a week with a massive gap at the back. So they do crop up occasionally, but most of them tend to be type 2s, which are fine to put in a collar, in traction for 6 weeks. If you need surgery to fix these, you can fix a pars, but you're always going to get a C2-3 listhesis because you've torn the disc. So even though you fix a pars nicely, you get a C2-3 listhesis. So don't just fix a pars, you need to do a 2-3 fusion. You can do it from the front, fixing the plate into the peg. Looks like I struggle a bit here. But the basic, what we're trying to do mostly is you can put C2 pedicle screws in across the fracture site. You can see these are half-threaded screws, so we're compressing a fracture site. And you put C3 lateral mass screws. And that's a typical spondylolisthesis fixation. So you're basically going to do a 2-3 fusion from behind. I'm going to go through there's the AO spine classification systems. I don't like the AO spine for the neck, so we use the Ferguson-Allen, which is more mechanistic. So there's a couple of different ones. You got the compressive flexion, vertical compression, DF, CF, and so on, lateral flexion. So the classic sort of burst fracture will be your vertical compression. And then you get compressive extension. You're almost never going to see those. Okay. So the ones you're going to see are the facet dislocation, which is your DF injuries. And there's different stages. So stage 1 is just facet subluxation. 2 is the unifacet. 3 is bifacet, and 4 is a complete olisthesis. Eh? So that's a simple DF. Another one you're going to get is the your CF injuries, compressive flexion injuries. Okay, so see here, that's a so-called the ends of the so-called teardrop fracture. So in stage 1 is just blunting. Stage 2 is more sort of wedging, but there's no fracture yet. Stage 3 is a small little teardrop fracture. Stage 4 is reticulolisthesis, and stage 5 is listhesis more than I think it's 3 millimeters. So that's your Ferguson-Allen compressive flexion injuries. So you must know those two. Know the DF, the facets, and the CF, the sort of teardrop fractures. Okay, so stage 4 is less than 3 millimeters, and stage 5 is more than 3 millimeters translation. It means you've torn the ligaments. Okay, that's a very simple classification. I find the AO quite cumbersome for the cervical. I'll just skip through this. What fracture is this, guys? The CF, what grade do you think? Cock?
I think it's grade 4.
Yeah, so there's reticulolisthesis, but less than 3 millimeters. So I agree with you, stage 4, eh? And there'd be a stage 5, eh? I won't go into the distractive extension. That's more like you rarely see those. What's this now? That's extension. Okay. Distractive flexion. So this will be a CF1 where both facets are still in contact. Yeah, we can see it looks like here's the other facet here. So this facet sitting there. These two are sort of lined up. Above it, there's listhesis, but less than 50%. We can see a facet sitting here. It's your classic bow tie sign. This facet still in contact here, so it's a unifacet. So it's a DF type 2. Here we're approaching 50%. Looks like both facets have jumped. So it's probably a DF type 3, and a 4 is complete body dislocation. Okay. Surgery, I won't go through this too much. It's probably an ACDF. That's a classic operation from the front anterior approach. We go between find the sternocleidomastoid and we find the carotid sheath, and you pull the aerodigestive tract immediately, and you go down on the carotid sheath, find your level, and it's very easy. It's almost like a nice fascial plane. And that's a standard approach for the anterior part of the neck. That's a simple plate with a autograft to take the disc out. And that's a standard sort of ACDF. You can do a corpectomy through that approach. You can take the whole body out and put a piece of tricortical bone or a strut there, like a fibula, and just plate around it. Posterior options are lateral mass screws. So they go into the lateral masses or the facet joints of the vertebrae. We aim laterally to miss the vertebral artery. So you start in the midline and you aim lateral past it. You don't want to go through, otherwise you hit the exiting nerve root, which comes out there. So it'll be a typical lateral mass fixation. Put the screw in. It's not the best biting screw. They are, but you aren't biting really hard bone. But if you get lots of them, you get quite a good fix, and you fix them into the rod. So that's a technique. You can see we're going laterally to avoid the VA and the nerve root. Yeah. You put them to these polyaxial screw systems, and you can put a rod. So multiple fixation points, it gives you a nice strong fix on the back of the neck. There's a patient prone, some tools, put the lateral mass screws in, and that's how it looks. Put the rods in, and you fix. Any good questions? Okay, let's go in the thoracic spine. This is when we get more into the AO classification. So we often mix our terminology. People talk about burst fractures and chance, wedge fractures, and it's probably words we understand because it's easy. I mean, you talk about AO3, B2. I mean, I still don't fully get it, but so we tend to use what we call it the Denise classification to describe them, but you need to know the AO classification. So Denise is the most common one where you describe it, and we probably use it to talk to each other about it, but when it comes to academics, we use the AO classification. There's a TLX as well, which I don't really use. I think it's quite complicated, but you're welcome to use it if you want. So this is so basically this is the Denise classification. So they took the three columns of the spine. You got the anterior column, which is your disc, the middle column, which consists of your posterior part of the body, and your pedicle, and that's your middle column, and the posterior column is your interspinous ligament and spinous processes. So they've got compression fractures, a burst fracture. A burst fracture's got the interpedicular widening. Then you got the, I can't see my screen because there's bloody things in the way. Yeah, then you got your chance fractures, which is a seatbelt injury. So I think I was speaking to Zama today. So if you got to have a chance fracture, you want no compression in the front, okay? It's got to be opening widened. So you can have a bony chance or a ligamentous chance that goes through the disc, maybe the facet joints and interspinous ligament, or it can be a combination of two. But a chance, you never have flattening in the front. So your point of rotation on chance is infinity, and it only makes the vertebra wider, whereas all the others, the compression fractures, the front of the body is narrow, okay? So just in your head, separate that. These one are what you call the type C injuries. So the AO is the one we use, and I think most of us understand it. TLX. Look, I mean, you can know it, but I don't think we're gonna just keep things simple yourself. Know the Denise, know what a burst, the chances, and yeah, and a wedge fracture, but then use the AO classification. I find the TLX a bit too irritating, to be honest. So you've got the AO. We'll go through that quickly. Your type A0 are your non-structural fractures, like a TP or something, or a spinous process. These are relevant. A1, wedge compression. 2 is a split. 3 is an incomplete burst, so only one without the end plate. And 4 is a complete burst when both end plates are involved. So there's A3, incomplete burst, and an A4, complete burst. So we all know these. Now you need to modify those, or you need to describe those in terms of the posterior elements. So if you have a B-type injury, it means it's unstable. So the B1 is basically a chance-type fracture, so it's widened to the back. And the B2 is just a posterior band disruption, so either a tear there in the interspinous ligament, which can extend into the front. type C. So any translation, the coronal or sagittal planes are type C, and those are all highly unstable. So that actually makes it quite simple when you're doing thoracolumbar fractures. You can have these neurological modifiers as well, and so on. Okay, so there's no one classification which is the best. When we talk about things, we talk about the Denise, but we should use the AO classification. But indication of the surgery are still pretty much the same. So if you have all three columns involved, and the Denise is three column system, A is a 2-column system. So if you have the front column involved and the posterior column involved, that's unstable. Patients with progressive neurological deficit, significant kyphosis, more than 30 degrees, and canal compression. Those are indications for surgery. Most common operations are short segment posterior fixation. I might have a picture here. So basically, what's some pictures here? Go through there. So basically putting pedicle screws in, okay, into the pedicles. And we then are distracting. So you've got these polyaxial systems where you can change the angle of the screws, and you can cause distraction and lordosis by altering those angles. There's a typical, what you call a Denise would call a burst fracture. There's retropulsion, and it's unstable because there's, well, I can't see it so clearly here, but you expect to be a disruption of the ligament here, so it's unstable. There's a patient on the frame. You can see here nicely the disruption, the posterior ligament, the PLC, and that's what you're feeling. So when you examine these patients, you mustn't feel up and down in this plane. You must feel side to side, and you'll feel the spinous process, but between it, you'll feel a nice cord of ligament there. And then it's very obvious when you reach it, once it's disrupted, your finger falls into a gap. So it's not an up and down feel, it's a side to side motion. These are Schon's pins, and you can see you've got these polyaxial clamps which clip on the rod. And you can put the screws in converging because the facets, the bodies are kyphotic. And you can cross them over, you can diverge, you can get a nice correction of your angle. That's how it looks. So there the screws are put in, and now we're basically opening the screws on the front by closing it like that. And then you lock it in place, and that's a nice fixation. So you can see how nicely the body height restored by causing lordosis. I'm just going to go back a little bit to that one slide because I think someone asked me about the McCormick and Gaines classification. So the most common thing we do is a short segment fixation, so one above, one below. If you have okay, don't know that. If you have severe comminution, so okay, so this is what you're doing. So by fixing below and above and distracting us, you're using ligamental taxis to align the fragments, and you're indirectly decompressing the canal. Okay. So occasionally one of these posterior fragments flips around, and we call it the reverse cortical sign. So this cortex, this is cancellous bone, which should be inside the body, is now flipped around and sitting in the canal. This is a reverse cortical sign, and that means the PLL is disrupted, and you can't get this back by ligamental taxis. So if you do see this, you see the cortex on the wrong side, this is unlikely to reduce with ligamental taxis. Okay, so McCormick and Gaines, they also they looked at these fractures with short posterior segment fixation and said if you have too much comminution in the front, you will fail. So their classification looked at comminution, the fracture opposition, the sagittal deformation, and they gave you a score. And if you scored 7 out of 9, then your posterior fixation will fail. There we go, 6. So if you score 6, then you unlikely to maintain correction with only posterior fixation. The problem is though, this classification is way back 1994, and it is based on using these Steffi plates, which is a horrible system. You can see it's got these little screws that look like they come out of the hardware shop. It's stainless steel. They're not fixed angle screws. So it's a very bad system. So it's not really applicable to modern pedicle screw systems, But just know about McCormick and Gaines, and basically saying if you're excessive comminution of the body, excessive kyphosis, and the fragments all separated, you need anterior column reconstruction. But that's based on a very bad fixation system, not in the modern one today. And most of the time, we very rarely do anterior column reconstruction. Only time I'll do anterior column reconstruction is if I've got a patient with neurological deficit, and I've got a big reverse cortical fragment in the canal. Then I may choose to go from the front to remove this fragment. Okay. Okay, so it's going to quickly go through what neurological systems you need to know. For those who are coming in, so we all know about the Frankel grading. So we tend to use for trauma the Asia grading, Asia score. You know, you basically get a score the patient like this. You get a motor score, you get a sensation score. And the difference in Asia and Frankel is that Frankel looks at the last working motor level. So a C6 complete patient will have no C7. The C6 motor might be weak. In Asia, you look at the last normal level. So in Asia, a C6 level may have some C7 sparing, but the C7 is weak. So we don't regard the last normal level be C6. So Asia looks at the last normal level. Frankel looks at the last working level in terms of height. That's the only difference between them, basically. So we talk about the Asia scores now. So you must grade your patients with Asia scores. So Asia A and Frankel the same. So A is complete, no motor sensory function distant to the injury. B is incomplete, so sensation preserved. C is motor present but useless. D is motor present yet useful, so 4 to 5, and E is normal. Quickly, just remember to, when you have a patient in spinal shock, what is spinal shock? So it's not low blood pressure. Spinal shock is absence of physiological activity in a cord because of injury. And so the cord's almost like a reboot mode. Nothing's working, no reflexes are working. Your blood pressure's dropped, everything's not working, okay? So that's what spinal shock is. Neurogenic shock is low blood pressure because of spinal shock. So that refers to your blood pressure, So the other thing about spinal shock is while the cords aren't working, you get no way to tell if there's any residual function, because even the normal pathways have shut down. So you can't say the patient's complete or incomplete while they're in spinal shock. Okay. Remember your patients. If you've got an unconscious patient, it's a common exam question. You'll be asked, patient's got a head injury. You potentially got a step in the back. How do you know they've got a spinal cord injury? Well, if they've got warm peripheries, they've got bradycardia and low blood pressure. That's typical of spinal shock. Bulbocavernosis, remember, it's a normal reflex. We all have it, but it's suppressed. The spinal cord's damaged, then you get a very brisk reflex. It's unsuppressed by your cortex. And while you're spinal shock, there's no bulbocavernosis. It's the lowest testable segment we have in the spinal cord, and it's the first one to come back once spinal shock is over. So that's why we look at the bulbocavernosis, not your knee jerk or the other reflexes. The first one to come back is your bulbocavernosis, because it's the most distal tip of the cord. So while you get no bulbocavernosis with patient spinal shock, you can't say the complete or incomplete. Priapism, just remember that. So priapism occurs at the time of complete cord injury. So if a patient gets priapism in hospital, it means the cord's died in hospital there and then, not prior to hospital. It takes a few hours and settles. It's a high flow priapism because you got unopposed parasympathetic activity. The sympathetics will shut down. So it's a high flow priapism, and it's usually a medical legal thing. The patient has an ER, it means the cord is basically stopped working then. You must all know the central cord, the incomplete cord syndromes. So there's certain patterns. Central cord. It's actually not correct. It's not. There is no central cord damage, but it's called central cord syndrome. There's new theories as to what happens now, but basically central cord is your upper limbs worse than your lower limbs. Okay, so it's a typical elderly patient. Usually an elderly patient stumbles, he's got a slightly tight canal, gets a hyperextension injury of the neck, and he ends up with very poor upper limb function, hands don't work, and there's preservation of the legs. A lot of the patients that come in at initially, you think they're complete injuries, and they turn out to be quite a dense central cord syndrome. So you usually might find something come back in the legs. They do have a much better prognosis because it's an incomplete cord injury, but often the patients, even though they can walk, they get poor they get poor dexterity and poor hand function. Anterior cord syndrome is basically anterior pathology, like an osteophyte or something, or fracture, which damages the anterior spinal arteries. So you lose your corticospinal tract, which are motor tracts. So it's basically motor fallout. Okay, so you may have preservation of your spinothalamics, and they usually don't recover because it's an infarct of the cord. Branchial cord, you see lots of these are stabs. So it's hemitranssection of the cord. So it's ipsilateral motor lost and contralateral pain and temp. I don't know how it works, but these patients seem to rewire the spines. So they often come in, they may have one leg completely flaccid, but they seem to reassign ganglions and they start to recover. So most of them have a very good walking prognosis. They'll recover in terms of motor function. So that's a very common thing we see in the unit. The posterior cord's very rarely seen, but basically damage your posterior columns, lose vibration and sensation. Probably find if you've got a calcified or a flavum which buckles in, you can cause a posterior cord syndrome, but I've never seen one. Conus medullaris syndrome, that's very common. So remember your spinal cord ends at L1 level, so you've got this conus. This is a mixed picture, so you've got basically a mixed bundle of peripheral nerves and spinal cord. So you get a mixed upper motor neuron lesion and lower motor lesion. And often these patients have permanent bladder and bowel dysfunction. The bowel cavernosus may never come back. You might get some limb function, so patients' legs might be normal, but they often lose permanently their bladder bowel function. Okay, you know, the cord equina syndrome. That's usually a large central disc prolapse catching your roots of the bladder. Yeah, that's not really a cord injury though. Okay, how are we looking? 1 hour. Anybody in questions?
Nick, I was just wondering one thing. With some of the TSAs, I see one of the surgical options is a C1 to 3 fixation. When would you think that you need to go from 1 down to 3?
For hangman's.
Oh. Would make you go that far to add that.
For the spondylolisthesis, you're basically gonna go. You don't fix C1, you fix 2 to 3. Sorry, maybe I said it wrong. So
no, I think you only had 2 to 3. I think I just read somewhere that C1 to 3 is also an option. Do you think that's over?
Take C1. So your C1's normal there. So you know, C1 to joints, very important joint. You know, it's 60% of your rotation. Take it away. The patient's using subaxial spine. They're going to get a lot of OA degen. It's not a happy joint to take away. So for a hangman's fracture, it's simply a fracture on the pars of C2, and the C2, C joints disrupted, I definitely would leave 1 out of it. There's no reason to take it. It may be that they feel they can't get a good fixation because maybe you've only got, the fracture line is there, you've only got some screw threaded to C2, but I don't think I don't find that a problem, because I don't have a CT here, but I mean, you haven't got the whole length of the pedicle to fix plate, but if you triangulate your screws nicely, you've still got a good distance in the body, maybe 15 mils, and it's quite hard bone. So I haven't seen one fail that's been fixed surgically. But maybe, I guess, what you're talking about, if they feel you can't get a good purchase in C2, you might get a C1, but it's a hell of a joint to take away. I would not do that lightly. Does that answer your question?
Cool, thanks. Yeah, thanks.
Okay, so I mean, I haven't got, there's lots of other stuff you need to know in terms of the classification of C1 odontoid of your occipital condyles. There's a bunch of them, but the common ones are you're going to see your neck, your dislocations, burst fractures, your AO classification for your thoracolumbar fractures. That's all you need to know. Don't make it too complicated. Most of the time, you only get examiners who are not spinal surgeons, and they vaguely heard of these things. Yeah, if it helps. So I haven't gone through all the different tiny little fractures and things.